So let's go back to the point, and Masatoshi, I'll ask you, because exactly as we heard from Arndt, is he would be keen on, if there's a resection, is to make sure that we take care of the hepatitis C. So please tell us, what's your current practice in regard to the treatment of hepatitis C in Japan?
Hepatitis C, usually we, of course, all the hepatitis C patients with compensated cirrhosis or chronic hepatitis, we eradicate by antiviral therapy. And after, if the patient receive a resection or ablation with still the HCV positive, of course we perform, we treat with antiviral therapy. So, but there is so another. I remember another trial that performed Masatoshi performed the interferon as an adjuvant setting.
Correct.
But in a short period, there is no effect for suppressing the recurrence. But for the long term, there is an effect for suppressing the recurrence, which means secondary carcinogenesis was suppressed. So the DA therapy, antiviral therapy, I think many people think in the long run the secondary carcinogenesis will be suppressed, but not intrahepatic metastasis.
No, that's a great point that you bring up, because remember, there's one of the arguments in regard to performing transplant on patients with hepatitis C, especially because there's a concern about the bad soil, as Rich just mentioned to us per se. So that's a very, very important point. I think we probably all will agree that if we have a resection, a curative intent, there's hepatitis C to treat it. But Rich, I have a question for you. What's your thought in regard if somebody has systemic disease and actually advanced HCC, metastatic HCC, would you give antiviral therapy for hepatitis C?
You know, I don't think that most people would treat those patients. There's a cost-effective question, right? It's very expensive, and these patients won't live long enough to see a benefit from that systemic treatment.
And I think there's no data anyway, like
for sure,
in regard to safety or even value.
Yeah, you know, safety, I suspect, is probably okay. Then again, it has been extensively studied. The studies with the DAAs excluded patients who had liver cancer. But to be honest, as we see that there are some patients who are doing very well with some of the systemic treatments, it does come into play over time, right? You know, look, this patient is on a certain side of the curve. They're a long survivor. Maybe it is considered for some of those patients.
Fair. I hear you. And Arndt, would you treat anybody with hepatitis C if they have metastatic disease? What's your thoughts?
I think it's really difficult to address. So first of all, I mean, there are some data on patients that have metastatic disease and have received treatment, antiviral treatment, and they have shown that the response rate or sustained viral response rate is not as good as for patients without tumor, so it's just around 70%. I mean, usually would expect almost 100%. So, I mean, it's obviously not as easy to treat these patients. I mean, they are a little bit more difficult to treat, but still, I mean, huge success rate, 70% is not bad. So actually, so should we treat patients? I don't know. I think at the moment we are not doing it. On the other hand, I mean, for hepatitis B, I think we can all agree on that patients with hepatitis B will be treated and that they have a benefit from the treatment and that the outcome is better for those patients that receive antiviral and anti-tumor treatment. So I wonder why would that be different in hepatitis C? Yeah? In respect of immunosurveillance after curative treatment, I do get the point that there could be something, but if they have metastatic disease, and if we have no effective drugs available and patients live longer, most likely, I could imagine that it could be worth to also treat these patients. But clearly, to address this point, we would need prospective clinical trials.
No, I hear you loud and clear. If anything, I totally agree. And we're going to come to that point a little bit later as we talk about therapy. But for hepatitis B, by all means, we definitely got to treat. The virus got to be under control. In regard to hepatitis C, really, there's no clear understanding. And if anything, as we already heard or suggested, that there's no data that really talks about treating hepatitis C in the setting of the presence of systemic HCC. As we heard from Dr. Fenn, really the data doesn't even exist in that regard because because those trials included patients with HCC. If anything, there's even data that talks about potential that you might actually worsen the cancer by the treatment, even though this is extremely limited data that came from few reports here and there. So I would say that still the idea is that, as we also heard the suggestion, a Hep B is an active virus. It really can integrate in our DNA material, and getting rid of the virus will be very critical per se. On the other hand, the Hep C really, it causes certain damage. It's an RNA virus. It causes certain damage, and really afterwards, it's really the damage itself that becomes the problem, not the virus per se. And as such, really, it's understandable why the applicability or the usage of antiviral therapy for hepatitis C in the setting of metastatic HCC will require probably further data or further analysis or clinical trials, which we don't have at this point in time. That really brings me to another point to ask, which is not necessarily something that we commonly use, but it's nice to hear all the perspective from all over the world. And I'll start with our friend from Japan, Dr. Kudo. And Masatoshi, so a patient comes with a tumor that might ultimately be resectable, but the surgeon would like to see it a little bit smaller, i.e. they would like to see some neoadjuvant or some conversion therapy to make it smaller per se. I might be totally wrong, but does this approach at all exist in Japan?
No, at the present we do not.
You don't. Fair enough, fair enough. And I think the same thing aren't for Germany or Europe, like an approach of trying to reduce tumors so it can become resectable, because this is a practice we use in other cancers in different malignancies.
I think it really depends. I mean, sometimes, the question is, and we had this discussion before, who decides whether a tumor is resectable or not? So it depends on the liver surgeon. So some surgeons might say no, the others might say yes. So, this is the first question you need to ask somebody who has really experience. On the other hand, if you have a large tumor, which is really not a good candidate for resection, if you do a local or whatever kind of treatment and you shrink the tumor, it's not neoadjuvant, it's downstaging, yeah. And so I think we can downstage some patients, and we also discuss it in our tumor board sometimes. So if we have here a tumor which gets a little bit smaller, then we would do the resection, and not only downstaging, it's also to learn a little bit about the biology of the tumor. So if it's a large tumor, or if you have 2-3 metastases around the tumor, so is it a tumor which have like very early recurrence after local therapy? So we do some kind of selection with these downstaging and selection of appropriate candidates. It's rare, but it's something what we are doing in our treatment algorithm. Yes.
No, absolutely. If anything, really, the only example that comes to my mind is this is like really relatively old now. We had the regimen of platinum interferon, adriamycin, and 5-fluorouracil, the PIAF, and if anything, it was tried here and there, despite that it did not show necessarily any survival advantage compared to doxorubicin at that time, but nonetheless, it definitely did show that there was a potential for resectability after giving that therapy. I would not necessarily say that we're recommending that in any way, shape, or form because it was rather toxic, but at least there was an attempt here and there to divert or convert a certain disease from being non-resectable to become resectable, either by systemic therapy or, as we heard from Dr. Vogel, also by the use of local approaches of therapy, which will bring us actually to the second point to discuss in the program, which is the locally advanced disease. What shall we do about them? And I'll start again with Masatoshi. So patient with locally advanced disease in Japan comes in, heard about something local therapy. What would you recommend? What will be the standard of care?
So local advanced means intermediate stage HCC.
Fair enough. Fair enough.
In that stage, we of course standard of care is TACE. So, and sometimes in Japan, sometimes the multifocal disease, in the past, very frequently we performed hepatic artery infusion chemotherapy using a low dose 5-FU and cisplatin. But recently, it's because the systemic therapy became a very good systemic therapy agent came in. So the multifocal disease may be not so frequently performed. Arterial infusion chemotherapy is not frequently performed. And in Japan, Y90 is not approved, so we do not perform.
So if anything, we hear that you'll use probably a chemoembolization, and also there's a Japan-specific approach to give infusional chemotherapy into the liver with a platinum and the likes based. And if anything, Richard, TACE, your thoughts?
Well, I think when we're talking about intermediate disease or Barcelona B, this is a heterogeneous group of patients, but needless to say, they're well compensated liver function and they have a tumor burden that is multifocal or not resectable with curative intent. And the backbone for that has been chemoembolization. The liver vasculature lends itself to that approach, but the studies that define the role for TACE were pretty stringent in their inclusion criteria. And what has happened is that has expanded over time, right? And part of it has been expanded because there was a vacuum for other treatments, right? There was nothing else to offer patients. But there's no doubt that for an intermediate patient, a true intermediate patient, TACE is the backbone and the standard of care. There's been interesting data developing with radioembolization showing that it's, there hasn't been head-to-head comparisons with TACE, but single institution series show that it's very active in controlling intratumoral disease. Maybe it's better tolerated because it's not embolic. It doesn't block the blood supply, so you don't get a post-TACE flu-like illness, transaminitis. But needless to say, both of those techniques have their limits. And it's important to use these approaches appropriately. No one would say that these treatments are going away in the management of liver cancer. They shouldn't. They've been shown to help people live longer, but they also have their limitations.